Hi, I'm Jerry Tan. I'm from Western University in Windsor, Ontario, Canada, and it's a pleasure to be invited to present an updated classification of rosacea. I wanted to ask you whether the classification system you use for rosacea is, number one, patient-centered, is it accurate, and is it specific to treatments that you can offer in treating your rosacea patients? I have conflict declarations, which are on the slide. Let's talk about the agenda. What is this new classification system? How was it developed? Why was it needed? And whom is it meant for? We know that rosacea patient presentations can vary from patients with erythema, maybe erythema plus telangiectasias. Possibly they might have flushing, also called transient facial erythema. They may also have presentations with papules along with all of those other features we just talked about, and then phyma or skin thickening, and patients with ocular features as well. These features encompass the entirety of the way patients with rosacea can present to us. And defined, it is a chronic facial inflammatory dermatosis, multiple characteristic clinical features, that's rosacea. And these features are the observable characteristics or traits of the disease, which is otherwise defined as phenotype. So what I'm presenting to you is a phenotype diagnostic criteria, as well as a phenotype classification system to distinguish it from where we had some issues with subtyping. So with diagnosis, only one is required of either persistent centrofacial erythema. Of course, as dermatologists, you would exclude lupus, seborrheic dermatitis, facial atopic dermatitis, seborrheic dermatitis, but we're trained to do that, so we can exclude those possibilities. And for phyma, there are very few other diagnostic criteria for phyma. The differential for phyma might be rhinoscleroma, certain types of lymphoma, which is very rare. And then the major criteria for diagnoses include any two of the following: transient facial erythema, inflammatory papules and pustules in absence of comedones, telangiectasias, as long as you exclude the ones that are solely alar telangiectasias. Why? Because those ones are ubiquitous in patients who have who just have normal skin. They don't have to have rosacea to have telangiectasias in that location. Ocular features, and then the minor features, which are not required for diagnosis, but are important to be aware of, are burning sensation, stinging, edema, and dryness. The reason for that is they can be extremely helpful in certain phototypes to direct you to the diagnosis. Plus, there's enough groups of patients that present with those symptoms that you want to try to ensure that your treatments offered also address that type of skin dysesthesia. The Global Rosacea Consensus Panel was gathered to try to elucidate some of those diagnostic criteria through consensus voting, and then a face-to-face meeting for clarification of any of the propositions. It encompassed 17 dermatologists from across the world and 3 ophthalmologists to help us pin down the criteria for ocular rosacea as well. This culminated in a publication in the BJD talking about the rosacea recommendations from the consensus panel in terms of diagnosis. And this classification that was entitled the phenotype classification was also endorsed subsequently by the National Rosacea Society. And it is now also in dermatology textbooks in Fitzpatrick as well as in Rooks. So why was a new system required? Well, we identified shortcomings in rosacea diagnosis and classification, and the old system, the diagnostic criteria, were based on primary features being present, one or more, and secondary features which were by themselves not necessarily diagnostic. The primary ones were. What were they? flushing, non-transient erythema, papules and pustules, and telangiectasies. Let's look at each one of these and evaluate what their shortcomings are. The first is flushing. It has a low predictive value, and you know that because there are so many other causes of flushing, including emotional flushing, flushing from medications, flushing because of perimenopausal situations. So by itself, flushing is not a highly predictive feature for the diagnosis of rosacea. Papules and pustules, folliculitis, acne vulgaris, those are probably more common than simply the papules and pustules of rosacea. So again, it has a relatively low predictive value. And then telangiectasies. Lots of patients have telangiectasies. A lot of that may be in patients who also have sun damage. So again, there's a concern about low predictive value. And one of the secondary features that has a high predictive value, which is phymatous changes, is actually in the old system, not in a diagnostic criteria for determination of the diagnosis of rosacea. And the question was why? So furthermore, looking at the old system, they had subtypes classified into subtype 1, erythematotelangiectatic, which included the presence of flushing and centrofacial erythema and the potential for telangiectasies. Papulopustular was the presence of centrofacial erythema with transient papules and pustules. Phymatous and ocular you see listed based on skin thickening and the ocular features, foreign body sensation, as well as the dysesthesia of the eyes, lid, and lid sections and lid margins, including blepharitis. The problem with subtyping is what I call confusion by conflation. Patients present with one or multiple features, and they don't necessarily neatly fit into each of these subtypes. So what do? You make them fit, or you don't make them fit at all. And if they don't fit, what are you going to call that patient? What would you call a patient who has flushing only? They would fit into none of these criteria because flushing is required along with centrofacial erythema to be called erythematotelangiectatic subtype. What if they only had centrofacial erythema and no flushing? You couldn't call them erythematotelangiectatic because flushing is required. So that is a problem when we're trying to push everyone with multiple features into groups that are artificially constructed. And that's not necessarily how patients present. The other issue with subtyping is what I call confusion by overlap. That is, with facial erythema, it can traverse from subtype 1, subtype 2, subtype 2, subtype 4. So if you're trying to study that condition and its prevalence, how do you determine what the actual prevalence is when it can belong to any of those subtypes? So that becomes a problem because now it limits the way we can actually study these specific features. And that leads into more problems. And the problem, for example, is how we measure in clinical trials the outcomes of this kind of conflationary subtyping. So, for example, with ivermectin 1% cream, this study was done circa 2014. The inflammatory lesions of rosacea had features of large papules and pustules and then erythema within the same grading system. So, for example, in a patient like this who presents with moderate to severe facial erythema and then after treatment has improved to mild facial erythema and transient papules and pustules presentation with moderate and then has improved to almost clear, mostly pigmentation that's left now. How do you grade this? Well, you know that the papules and pustules have moved from moderate to almost clear. The erythema has moved from moderate to mild, but it's not one categorical improvement for both of these features. And the solution, of course, is not to conflate. The solution is to measure each of these separately, papules and pustules on the one hand, and then erythema on the other. And you might find that your specific medications do better on one feature compared to the other. And I think it's important for us to be aware because the likelihood is you treat patients this way. You know, there are certain treatments that are much more effective for papules, pustules, others much more effective for erythema. And there's really not a lot that's necessarily completely effective for both features to the same extent. How do we apply the phenotype approach for rosacea practice and research? Well, we generated what is called a patient tracker so that at the visits, the doctor evaluates the features that are present on the patient, and the patient indicates the level of impact or how much they're bothered by it, so that we can then move forward with targeting the condition and the specific features that truly bother the patient the most. And then subsequent visits longitudinally to allow understanding of how it's improving over time and whether there are new features developing as well. This is a template to address the treatment based on clinical feature or the phenotype, the way that patient is presenting to us. So whether it's transient erythema, persistent erythema, inflammatory papules and pustules, telangiectasias, phyma, whether it's inflamed or phyma, no longer inflamed, can then have very targeted treatments based on either topicals, systemics, or procedural treatments. And within each of these is categorization of mild, moderate, and severe. And some patients, for example, with very mild conditions may not necessarily want to have treatments undertaken. Underscoring all the treatments is important and relevant, appropriate general skincare. What does that mean? Synthetic detergents that are pH balanced, that are very gentle to the skin with little in the way of surfactants that can irritate and remove natural moisturizing factors, along with moisturization and high-grade sunblocks. And then we follow that with the different options that are available for each of these features, depending on the features themselves. So let's see how this could work in individual patients. For example, this patient presents with both papules and pustules, as well as inflammatory phyma and centrofacial erythema. So the inflamed phyma, we would use the anti-inflammatory topicals and oral treatments as we had previously discussed. And then it would be combined with or followed by physical modalities if the patient is bothered and wants some of that debulking done for his excess nasal structure tissue phyma. Papules and pustules, the anti-inflammatory topicals and or oral treatments. In this patient, I would probably select to add in also a medication like doxycycline to try to give him fairly rapid and more thorough improvement when we initiate therapy and then maintain over time with the use of topicals as well. Centrofacial erythema, you can certainly consider the use of alpha-adrenergic agents and then some of the device-based agents to tone down the background redness. And you can see his redness is telangiectatic to a large extent, and the erythema is primarily lesional erythema at the sites of his papules and pustules. And at his nose, it's non-papulopustular, it's diffuse erythema. So in this area, it's very evenly distributed along with the erythema at his cheeks. This patient presents with the erythematopapulopustular subtype. And what I mean by that is centrofacial erythema and then the transient papules and pustules. And the treatment leads directly from what we see, which are going to be the anti-inflammatory topicals and or orals. And in this patient, I did end up using a cyclin along with topical ivermectin to try to give her as much improvement as rapidly as possible. Centrofacial erythema, we can certainly look at the topical alpha-adrenergic agonists and the device-based treatments. if she doesn't see adequate improvement with the anti-inflammatory topicals treating the papules pustules. Sometimes when you treat a lot of these patients with the papules and pustules, you see enough lesional improvement of erythema that they're much more comfortable so that you don't necessarily have to treat the centrofacial erythema. And the next case I wanted to ask you is, does this patient have rosacea? Well, on this imaging, you don't really see it on her natural standard photograph, but on the red spectral image, it's very clear she has nasal erythema, cheek erythema, chin erythema, along with the visible papules and pustules. So why don't we easily diagnose it? Because it's difficult in darker phototypes, and it's hard to see red on darker skin. So one of the ways to consider how to use the new diagnostic criteria is to remove all the erythema and focus on whether the patient might have phyma as a singular diagnostic criterion or major criteria on the basis of inflammatory pustules, which is what she had, telangiectasies, excluding those those that are solely alar. And the telangiectasies, if you are suspecting they have telangiectasies or rosacea in a very dark phototype, you can always use the dermatoscope to look for polygonal telangiectatic vessels, because that's got a high predictive value for rosacea. And then another major diagnostic criteria are the presence of ocular features. The minor features are helpful because they can direct you to the diagnosis if the patient is discussing from the symptomatic perspective that they have flushing, they have burning and stinging sensations, then they're very typical triggers for rosacea patients. Your history guides you to this diagnosis. And then when you examine, look for centrofacial clinical features, including phyma, including papule and pustules in the absence of comedones, and then including dermoscopy to discern those polygonal telangiectasies. So what we've done is updated the diagnosis and classification of rosacea using a phenotype approach based on presenting features. It was developed with consensus methodology, and it was needed because there were shortcomings of previous systems, both in diagnosis as well as in the subtype classification. Whom is it meant for? It's meant for us, clinicians and researchers, and it's especially meant for patients who have this condition. So the entirety of this update is towards accuracy, simplicity, and practicality. Thank you very much.